Well, good evening. Welcome to What, How, Why Wednesday, Black Women and the Maternal Health Crisis on blackdoctor.org. I'm your co-host, Tamara G. And yes, you heard me right. Our What, How, Why Wednesday was so successful that we moved it over to bdo.org, blackdoctor.org, Facebook Live with you. So thank you for joining us. And we would also like to thank the production team led by Mr. Ellis this evening. He is doing a wonderful job already. You know, he's got to be a bad man to deal with these four women right here. we are something else on this one. But exactly, he's the man to do it. So we're so happy to have him. And I want to introduce, of course, Dr. Kendra Outler. She is the one responsible for this and this wonderful talk that we're going to have this evening. She is an anesthesiologist in the DC area. And you have brought together a wonderful team of female doctors to talk about Black women and the maternal health crisis. So take it away, Dr. K.
Good evening, Tamara G. It's been fun having you with me all these Wednesdays as we talk about what is going on, how is happening, and why we need to have these conversations. And we wanted to make sure that we launched this program during May. And so today, of course, as we end the month, we want to remind everyone that we have a situation that's broad, very broad. And what it is Black women maternal health crisis. How are we defining this? What is the scope of the problem? Every year, 50,000 are killed due to pregnancy and pregnancy-related complications. And 700 women out of 100,000 will die from a pregnancy or pregnancy-related medical problem. And so this is very personal for me. If you are like my family who lost a dear aunt years ago, before I could understand what happened, this is more than about numbers. It's more than about a campaign. Some people may reflect on the recent movie Fatherhood by Kevin Hart. He touched on that subject. And again, it's more than about numbers or a campaign or a movie, about the unknown. Because for years, I didn't understand why there was somebody else in the house, but no one spoke her name. And I didn't understand who was this relative that my grandmother adored, but no one could make that connection. So it would take years before I could make that personal connection and understand that was my grandmother's deepest heartache to lose her only daughter. And so, on this last What, How, and Why Wednesday, we want some answers. And I came to two of the most beautiful women physicians that I could think of and find. And I went to Mississippi. And I said, okay, let me call out two of my dear friends, Dr. Myrna Alexander Nickens. I want you all to understand that she is a pioneer in medicine, even though she blushes and doesn't like to say too much. Yes, I'm going to give you all the praise and lay it on thick. The sister finished from Meharry Medical School. I won't say what year, but she had a good reunion. And she did her internship, her residency, hear me clearly, and her fellowship in the Motown city of Detroit, Michigan at Henry Ford. So that is no small feat. And she is the first interventional cardiologist, Black female interventional cardiologist for the state of Mississippi, not the city of Jackson, the state of Mississippi. So with that, we definitely want to always give you your propers, as we say. And we also have who I called on, my dear friend, Dr. Michelle Owens. And so I'm going to do an abbreviated bio for Dr. Owens because we only have an hour, but this is important. And she is a maternal fetal medicine specialist, subspecialist and professor in the Department of OBGYN, Obstetrics and Gynecology at the University of Mississippi Medical Center in Jackson, Mississippi. She completed her residency at Johns Hopkins, and she went to Mississippi to do her fellowship in maternal fetal medicine. I'm sure there was a lot of work to be done in that area there. And so again, this is no small feat. And so I brought you some of the best sisters I could find in the business. And I want you also to appreciate that she is on the board of directors of the American College of Obstetrics and Gynecologists Executive Committee and part of the Mississippi Women's Foundation. Her research includes and clinical interests include maternal health equity, preterm labor, sickle cell, hypertensive disease, and substance use disorders and pregnancy. So in terms of discussing this crisis, the Black moms and the maternal health crisis, I brought you the very best to get us at some of the what, the how, and the why. So Tamara G, Let's take it away in terms of recapping what we've been doing, and then we'll start.
All right. Well, if you have not been joining us, and I don't know where you've been this whole month of May, we've been having some great topics. We kicked off May with talking about sleeping and getting enough of that, rest, and also sleeping disorders. We then went into talking about plastic surgery and how that is changing Black America and changing in Black America with Black women and men getting plastic surgery. And then, of course, last week was reclaiming your energy and reclaiming how to get your mojo back. And this week, we're going to be talking about, of course, the moms and what is happening in the maternal health crisis, particularly as it relates to Black women. So, just so happy to be here. Listen, I've learned a lot being with all of these doctors. I am really learning something that I never knew anything about, and I hope that you do the same. If you would like to make comments or you have questions, please put it in the chat there and we will get to them as soon as we can. We have an hour tonight with the doctors, all three of them, who will be giving their insights on this, and we're just so happy to have them. So I would like to start. I know, Dr. K, did you want to play the video first? Or
Let's bring on Allison Felix video of Hear Her Now. This is a very important message brought on by the CDC. And the Hear Her Now campaign looks at women's stories in terms of how they struggled with their pregnancy. And it kind of, Allison Phoenix is a world-class Olympian, and she's also lent her voice to this crisis.
I was so married to the birth plan. I imagined what it would be like, and I studied and I read and I went to classes, and I felt really prepared to have this natural birth. But what I did not prepare for was a scenario where everything goes south. Hi, I'm Allison Felix. I'm an Olympic athlete and a mom, and this is my story. Being my first pregnancy, I was feeling really great. I trained throughout my pregnancy. I was running every day. I was in the pool. I was lifting weights. I felt really strong. So it was my scheduled routine appointment. I was sitting back in one of the rooms waiting for the doctor to come in to see me. And when she did, she mentioned that she wanted to hook me up to be monitored. I started to think, I wonder if this is normal and I wonder what's going on. And finally, she came back and she said that she had some concerns and she wanted to send me to the hospital for further testing. That's when my heart kind of sank and I was like, wow, this must be something. I kind of heard of the statistics of Black women being more at risk for complications, but being a professional athlete, I never imagined myself in this situation. At 32 weeks, I was diagnosed with severe preeclampsia. My husband was coming from work and he met me there and we were sitting together and the doctor came in and she just said that things were still concerning and that they wanted to admit me to the hospital. That's really the point where things got scary. Doctors and nurses were coming in and they were concerned. And I remember at one point the doctor rushing in and saying that, we cannot wait any longer. We're going to have to rush you in for an emergency C-section. I am scared, I'm terrified, but I'm not really concerned about myself. I'm just worried about this little tiny baby who is not ready to enter this world yet. All I was thinking is just, I want a healthy baby. I didn't imagine, not even being able to be in the same room as my daughter and not being able to hold her until even the next day. And Cameron was in the NICU for a month after she was born. I stayed in the hospital for a while and I had some complications that come along with preeclampsia. It was just a really scary, tough situation. But I feel so blessed that I came out on the other side of it. There are so many women who do not walk out of the hospital. They are not there to raise their children. I really want women just to be aware, to know if they're at risk, to have a plan in place, to not be intimidated in doctors' offices, and to be heard. to be persistent about anything that does not feel normal, because I know how important it is. I know how scared I was, and I know how I didn't feel prepared or educated. And I don't want anyone else to feel that way. Hear her.
Wow. Wow, pretty positive. And, just so you guys know, Allison Felix is the most decorated woman in Olympic track and field history and the most decorated American track and field athlete in Olympic history. And even she had problems with a pregnancy and could possibly have died. So we want to talk about that. And it hit me that she thought everything was fine because she was an athlete, a world-class athlete. So we're going to be talking about a little bit of everything tonight with that, but I hope that you guys, take from her story there. Why don't we start with Dr. Owens? Dr. Owens, can you define the words maternal, morbidity, and mortality, just so that people will know what these words mean?
No, absolutely. So when we talk specifically about maternal mortality, it's essentially pregnancy deaths. So that is if a woman dies at any point in time during her pregnancy or within a year following her pregnancy, then that is counted as maternal mortality. And the way that it's reported, you'll hear these numbers, and it's not by percentages, but maternal mortality is given is the number of deaths per 100,000. So when you hear those numbers, they are alarming, especially in this country, considering all of the many advancements and technology that we have available. Those numbers are extraordinarily high for a country as wealthy as ours is. But keep in mind that that's not 700 out of 1,000, it's 700 out of 100,000. 100,000 births. And then when we talk about what maternal morbidity specifically is about pregnancy complications that can lead to short-term or long-term consequences within a birthing person's life that may be limited to their pregnancy or immediately following, or in some instances it can occur or impact their lives later on.
And of course, I'm sure you hear this all the time, Dr. Owens. People think that having a baby is the easiest thing to do because so many people do it. But, there are some consequences or some things that may happen with pregnancy. It's not a sure thing that you're going to come out of it alive, right?
No, not all. I tell people all the time, pregnancy is a life-threatening condition. You are, just by being pregnant alone, your risk of death goes up being pregnant compared to being not pregnant. So we normalize those things. We normalize cesarean deliveries because they're common surgeries. We normalize pregnancy because it's a thing that we are built to do with our bodies as women, et cetera, right? But in actuality, pregnancy is stressful and it creates a stress on our bodies. There is a huge adaptation that has to happen within us, as well as what people see on the outside is just the tip of the iceberg compared to all of the many changes that go on inside of us. And those things progress over the course of 40 whole weeks. So yeah, it is not at all as simple or as safe as many people believe. That being said, the good news is that the things that happen that are the worst tend to be the rarest. So more often than not, most people will have a reasonably good outcome, but it's really important to keep in mind that that's not a guarantee.
Okay. And let's go back to Allison's story, because yes, we heard it, but she didn't really go into any specifics about why she would have been there, or why the doctor thought that immediately they should put her into the hospital and have a C-section. Why, or what should we be on the lookout for that would make that, be a reality where hey, we've got to take the baby now because this is happening?
So typically when a decision is made like that, it is because there is either an imminent threat to the mother's health or well-being, or there's an immediate threat to the baby's well-being. And we use a variety of different informational points to figure that out. So we look at vital signs and other things about moms to help figure out whether or not moms are at a risk or having problems. And then we also look at fetal monitoring and other mechanisms to determine how well the baby is doing. So it's interesting. What she said is, while it is a very stirring story, that is very common, especially in a place where we are, where rates of preeclampsia, which she mentioned she had, are very high. It's very common in a labor and delivery type situation to have someone where everything's fine one minute, and then all of a sudden it's not. And going from being fine to not being fine can be very quick. And it can be very disconcerting, very traumatic for the families that are experiencing that. And it can also be really stressful on the healthcare team, because we realize that, you know, sometimes life and death are in the balance, and every moment counts.
Wow. So you mentioned some things like preeclampsia, and we want to, can you broadly define that? I want Dr. Alexander to talk more about cardiovascular changes, but the things that we see in preeclampsia, and like you say, when people, I was fine, and then as we go for the maternal visits, you may not be fine. So you go from your regular obstetrician, they may have to then send you to an MFM specialist, which is what you are, maternal fetal physician. So what is preeclampsia? And I know that we always, that most women will say you have to check a pregnant woman's urine, and what are we checking for?
Right. So those are great questions. So first of all, preeclampsia is actually a syndrome. It's a spectrum of different things that you can have. It's like your special kind of meal where you can pick a couple of things and put it together to make preeclampsia. So there's not just one thing. I guess if there was one thing, it would just be high blood pressure, right? So it's a high blood pressure problem that specifically develops during pregnancy. Now, that is different from those people who have already been told that they have high blood pressure. But those people are at an increased risk for developing preeclampsia as well. So you can have regular old garden variety, everyday blood pressure problems, and then develop a pregnancy-related blood pressure problem. So preeclampsia is just a term that we use to define a pregnancy-related blood pressure problem. So blood pressure, high blood pressures are one part of it. There are a series of other different things that we look for. And one of those is when you mentioned the urine, is looking for the presence of protein in the urine. And the protein is used to help us identify that there's some injury or some problem with the kidneys. So one of the things that having a problem with your blood pressure can do is it can influence your kidneys or make you have problems with your kidney function. And preeclampsia does that same thing. It can cause problems with the way that your heart functions. It can cause problems with you having headaches. It can cause problems with your liver. It can cause problems with your kidneys. And so when we see protein in the urine in a person who's not had protein before and they have high blood pressure, then those two things together are the most common way that preeclampsia can be diagnosed, but there are also a lot of other ways too.
Okay. Again, if you would like to put a question in the chat, please do so. We have some already. We're going to get to them in just a minute. Wanted to move now over to Dr. Alexander. I apologize. She is an interventional cardiologist. What exactly is that?
Okay, so during my lifetime, there's a spectrum of what I do. So when I was a little younger, I was an interventional cardiologist. Now I'm doing mostly clinical cardiology and more interested in cardio obstetrics. And we will talk about that. And my friend Michelle is the person really that got me interested in that. But an interventional cardiologist is one that really intervened in something that is going on. Say, for instance, someone comes in with a heart attack and they have a blood vessel that's closed, then we would take that person to the cath lab to intervene. So that's the interventional part. Mm-hmm. And we would put a stent in or do some other, there's a lot of stuff that we do now. But I have become a little wiser. And so my partners are doing that. My younger partners are doing that. And I'm doing more clinical cardiology than what I was doing initially. But sometimes we have had to take our pregnant women to the cath lab and to intervene in those women as well. And I think earlier we talked about cardiovascular disease being the #1 cause of death during pregnancy, and most people were surprised.
Yeah,
Like,
most people
how is that? How can that be? And so when we talk about cardiovascular, we're talking about an umbrella type situation. So it's not that you had a heart attack, but there's other modalities that's included in there. So one of them is preeclampsia, hypertension. Then I think Dr. Owens mentioned that you could have a cardiomyopathy where the heart muscle is not squeezing properly. And so those patients can develop that just from being pregnant. That, what she talked about earlier. And so we got people that are really, really young that develop cardiomyopathy. And then we got our older women that maybe have not had a pregnancy, or they've had multiple pregnancies and they develop a cardiomyopathy. So there's a lot of different, it's a big umbrella, but cardiovascular also including in that vasculature is strokes. So those ladies can end up having a stroke because of that blood pressure that Allison presented with. So that's why the physicians are running around saying, "Hey, we got to get this under control. We can't let this happen to this patient." And sometimes we are in the background. The cardiologists are saying, "Hey, wait a minute, wait. Do we have time?" And our obstetric, they're saying,
"We got to get this baby right. We got to get this baby."
But don't forget the anesthesiologist, because I got to see all this stuff. And then
you know what? Let me tell you, Dr. Outler, what we have developed here is a collaborative approach. So in that collaborative approach, there's a cardiologist that the maternal fetal medicine people are over it. Then we are together with that. And so there's cardiology, there is anesthesia. So we have our specialty. We have to include cardiovascular anesthesia as well as OB anesthesia. So sometimes we're having to pass off the OB anesthesia and then get to the cardiovascular anesthesia depending upon what the patient has. But so our surgeons are involved as well. Our cardiovascular surgeons may be involved in this collaborative effort. We also have nurses involved as well as social workers involved, because when the patient gets ready to go home or even before that, there's a lot of need for that patient, the mother and the patient.
Well, let me just let's go ahead. I mean, we did a lot of the specialties. So basically what I want to recap is that we do have patients that present as high risk, need a multidisciplinary team. You two are at the largest center in Jackson, Mississippi, and that's the University of Mississippi at Jackson. So tertiary centers like where you train Dr. Owens and where you train Dr. Nixon, and also where I train, are tertiary centers where high-risk women actually have to go, meaning you leave your community hospital and you may have to be referred to these big centers with big teams. And that's how we can guarantee, or we like to say that we can, improve the care for you and your ability to survive pregnancy, which Dr. Owens, you said quite succinctly, is a life-threatening condition. We also need to just, really just highlight the reasons that women do die. We have gone through an evolution in terms of the practice of obstetrics and gynecology. We've also improved anesthesia for obstetrics. So I've done OB anesthesia as well for my practice. But let's slow that down so people understand where this list is now. The American Heart Association, which is why we're here, and the March of Dimes have called for us to consider the #1 cause of death right now, or illness, in pregnant women, and that is your cardiovascular changes that happen during pregnancy, i.e. diseases such as preeclampsia. We rarely see eclampsia. But Dr. Owens, when someone is going to come in to see you, or what we're calling this list of life-threatening things that women die from during pregnancy, could you give us our top 4, please?
Sure. So cardiovascular disease or cardiac disease. So now it's heart disease is probably the thing that is the most prevalent. However, we know that about just under 20% of maternal mortality is due to preeclampsia. Hemorrhage is still a significant contributor to maternal mortality. Another one that is kind of becoming much more prevalent that wasn't as big of an issue, and you can relate to this, Dr. K, is substance use disorders and overdose. So that's one that we're starting to see kind of creep up and come into our top 5 in a way that we didn't see before. But hemorrhage, clots, the heart, so blood clots would be another one. Heart disease, which is probably that's the lion's share, and preeclampsia, with also issues related to substance use or drug overdose as being another big contributor.
Didn't we see a spike in that during the crack epidemic in the 80s, where we were dealing with both premature babies and maternal deaths?
Yeah, and it's interesting because it kind of all goes, I think all paths lead back to the heart in some way in a lot of these cases, because the crack epidemic and cocaine use puts a strain on your heart and your vascular system. And so most of the morbidity surrounding that was either related to heart failure or to myocardial infarctions, or what we call heart attacks. So those are the biggest contributors then. The other thing is that those kinds of drugs, especially the stimulants, increase your risk for problems with your babies, because it can influence when you have really high blood pressures or other vascular disease. It can also cause problems with the placenta or the afterbirth staying attached appropriately to the inside of the uterus. So that can come apart early, which can also be life-threatening for the baby and the mom. That's a clinical thing that we call an abruption, but it's actually when the afterbirth, if you can imagine, the afterbirth separating before the birth has actually occurred. And so that is an obstetrical emergency as well.
Alexander.
Yes.
Go ahead. I was about to say, I guess I'm more concerned because, you get through the birth. Thank goodness you get through the birth. And now you're telling me that I may even have complications after the birth up to a year.
Yeah.
I'm still, I could possibly still die. So, what has this done to the numbers? And I'll ask this to Dr. Owens, to the numbers of people having babies. Are we up? Are we down now? What are the numbers saying?
Well, so people are still having babies, but there are a few things that I think have contributed to this that makes it a little different than it was maybe 20 or 30 years ago. Women are having babies a little bit later in life. And that's whether they've chosen to wait or delay childbearing, or just to decide to have babies for a longer period within their reproductive years, right? Because you might get your new boo and decide that you want to start that second family after you originally had that experience at a younger point in time in your life. So number one, women are more active at the later parts of their reproductive years. I think the overall health of our population has changed, right? Obesity has gone up. With obesity, we've seen more diabetes, more hypertension. And so the people who have chronic medical diseases have also gone up as well. And so I think if you take those things and you put them together, people who tend to be heavier, they may have more medical problems when they become pregnant, and who might be pregnant later in life, it kind of creates the perfect storm for additional risk and additional complications.
And what have you seen?
And look, after the baby's out, it is not over. Don't believe it's over. And I think that is one of the big gaps that we experience right now, is that people believe, oh, I can't have preeclampsia, I'm not pregnant anymore. And there are even doctors who don't realize or don't know, because after you've had the baby, you don't think to tell the doctor when you go to the doctor with a headache that you just had a baby a month ago, or that you had a baby 2 weeks ago, because you're through with that and you're thinking about what's going on with you in that moment. But that information is still vitally important and can make the difference between getting the right treatment at the right time in a way that could actually save your life. So realizing that this thing is still continuing, your postpartum period, that trimester is really going to last essentially in your mind for a year.
Wow. I want to ask Dr. Alexander, what have you seen in women who've had babies and then have had to come in or had some type of cardiovascular issue?
So we see these together. When I say we, Dr. Owens and I see them together. So the patients may leave, normally they try to get you in and out of the hospital within 48 hours. Is that right, Michelle?
For vaginal delivery, if you have a section, we give them a couple of more days. So between
Well,
48
our child sweet and our child sweet. Thank you.
But anyway, they could go home, and like she said, they could come right back short of breath. They come back short of breath. And so now we're trying to determine, well, is it a blood clot to the lungs? Because that's quite common. Or is it something wrong with the heart? So we do have patients that present with pre-eclampsia. The heart is fine, but there's a lot of fluid in the lungs. And so that's called pulmonary edema. Okay. Those people generally do fine. You can treat them and they generally do okay. The patients, however, that have peripartum cardiomyopathy, where this may start a month before delivery, and it also can happen, say for instance, if the woman had a miscarriage and didn't have a complete pregnancy, but had a miscarriage, you can develop peripartum cardiomyopathy even after that. So you have to be careful with any pregnancy, not just the completed pregnancy. Well, so that peripartum cardiomyopathy, where the heart doesn't squeeze well, can be up to 6 months after delivery. So that's when the heart gets weak. And then that person, they're young people, right? They develop congestive heart failure because they can't breathe. They may come in, they may wonder, well, why can I not breastfeed now? What's going on with my breastfeeding? I'm getting short of breath, just breastfeeding. Well, that's one. Then we talked about preeclampsia. Now, there are some other rare ones, but the fact that we see them, we don't consider them so rare. We have to think about them. So you can have a heart attack where the blood vessels of the heart split. It's called coronary dissection. And we now have some ladies that even connect themselves. They have their own little sites, women that have coronary dissections, but sometimes it's related to pregnancy, and sometimes you can have it without pregnancy as well. But that's another unusual, but still we see it, not uncommon.
So the question becomes, since we know that postpartum period can be extended, and we also know that there's only so many patients, so many clinic visits you're given after pregnancy. The question is, are we now able to, are you able to have a tracking system for these moms when they go home? If they have any complaints, is there a hotline? Like, what is the fail-safe system so that hospitals that either where you are systems being implemented to help, because we're recognizing now more and more that it's not just the pregnancy time period, it's afterwards. And if I'm not mistaken, most of these what we call pregnancy deaths are actually in the 2 to 3 day window after the delivery. And you mentioned also the pulmonary embolism, which remember Serena was very vocal about her complaints, and she had a prior history of a PE, and she felt like she was not listened to. But that was after delivery, which would have been documented as a pregnancy-related mortality or morbidity. Didn't happen, but I'm glad of that. So what do we do now?
So I think that is a wonderful question. We have been trying. So nationally, there has been a huge patient safety initiative that is focused on addressing people who have or who developed problems related to cardiac disease or hypertensive disease, even in that postpartum period, and raising awareness. The problem is very much, as you mentioned, you go back for that 6 weeks postpartum visit, and when do you see your OB again? When the pregnancy test says positive, or if you're seeing them again in a year for your annual exam. So there's not really a plan in place for those people to be seen or to continue with surveillance. So the problem is that you get this fragmented care. So the next person that they may see may be their primary care doctor, or in many instances in lower resource areas like where we live in Mississippi, where they may go to a critical access emergency room, or they may go to an urgent care. And there's a person who doesn't know to ask them about their pregnancy history or whether they just gave birth, and they don't connect the dots. So what we've been trying to do is, number one, I've started educating my own patients to say, When they leave the hospital, I say to them, look, if you go to see any doctor within the next year, if it's the dentist, if it's an emergency room, I don't care what you go for. If you go in because you cut your finger, if you go in because you can't breathe, if you go in because your foot's swollen, you tell them that you had a baby. Tell them your baby's birthday. Because if you do that, that could actually save your life. I also tell them it is not normal if you cannot breathe laying flat. Because a lot of times what pregnant people will do in the immediate postpartum period is they will just decide that they'll sleep in a recliner or they'll prop themselves up on some pillows until it's comfortable, and they won't so that once they can get through it, then they don't have to go see anybody, or they won't see anybody until it's gotten so bad that they're way behind an 8 ball or worse. So the patient education piece is one thing. And the next thing is that we've been trying on a national level through our perinatal quality collaborative, reach out to hospitals and say, make sure that if you see a person of reproductive age, you know how in the emergency room, everybody's pregnant until proven otherwise. Well, if you think that way in an emergency room, then you should also think that maybe everybody's, if they could all be pregnant, they can be postpartum. So everybody's postpartum until proven otherwise. How do you prove otherwise, Dr. Owens? Well, you ask them. And if you say, have you had a baby within a year? So we've been trying to get people educated to make those subtle changes that might alert someone about a potential pregnancy related complication, and add that, you know, as part of routine medical care. Because if we do it for every woman every time, then fewer people will fall through the cracks.
Doctor, that's one of the first things they ask you for anything. Are you pregnant? Are you pregnant? I'm like, I hadn't been able to have babies in years. No.
Look, and they still run the pregnancy test. Check it out.
They don't believe you.
Did you want to add on to that, Dr. Alexander, before I go to
give us the medications, Dr. Alexander, that you might prescribe for someone with these issues, please?
Okay, all right. So if we're one of the symptoms that Dr. Owens talked about, where the ladies don't want to lie down, that's because they got fluid in their lungs from congestive heart failure or pulmonary edema. So that's why they're sitting in the chair. One of the medications we use is just a simple diuretic, is a furosemide or any diuretic. But that's one of the common ones that, you know, we grew up with, right? We can, once we look at the heart, you really do need to have some availability of testing, like an ultrasound, the same ultrasound that they're doing on the babies to see what age the fetus is. We use an ultrasound to look at the heart muscle. So it's called an echocardiogram. So we look to if that woman is symptomatic. So one of the indications is get an echocardiogram. That will tell us if there's a problem with the muscle or if the person had a heart attack. That echocardiogram will help us. We have to consider not only the medicine, but if the mom is going to breastfeed, so that the medicines that she uses is not getting into the baby's system. We have to consider that even when she's pregnant. So there's a certain group of medications we use for heart failure. Say, for instance, if we do have some ladies that have congestive heart failure and they get pregnant. I mean, they, you know, that's their problem, that they had congestive heart failure from something else. And then here they're getting pregnant. And we say, hey, did anyone tell you that you at high risk for death or having heart failure during the pregnancy? No, nobody told me about that. And so I tell my colleagues, hey, you need to talk to these ladies that are 18 years old and they are of age so that now they can get pregnant. So sometimes the medicines that I choose in a fertile woman are different for high blood pressure because I'm concerned that they may get pregnant. And so one of the groups is called ACE inhibitors. And that group of medicine is a great group, is a great drug, but it can be deleterious to the fetus. So we have to consider when we're giving medicines, and sometimes the ladies come back pregnant and they have had those medicines. We have to take them off the medication and put them on something else when they come to the office. But if they're in heart failure, then diuretics is something we use. We also, if once they get a little bit better, we use beta blockers like metoprolol, that kind of stuff. But that's easy, really. It's identifying, knowing that the person is in distress. So you got to diagnose it first. Once we get it diagnosed, then we have a pattern of what we give to the moms after that. But identification, because often women are short of breath because they're pregnant. Okay, so they gain 40 pounds and they, belly is way out here and they can't breathe and they're sitting up anyway, right? So it's probably hard for them, for our maternal fetal medicine physicians and our regular OB physicians they refer outside, in the community, they refer to them for special. Sometimes it's difficult for them to tell that this is something wrong. They may think that this is just regular pregnancy induced shortness of breath.
Gotcha.
But that echocardiogram will help us.
If you are just tuning in, first of all, welcome. I'm your co-host Tamara G to What, How, Why Wednesday, Black Women and the Maternal Health Crisis on blackdoctor.org. We are speaking with Dr. Myrna Alexander. She is a clinical cardiologist, and Dr. Michelle Owens of obstetrics and gynecology, both affiliated with the University of Mississippi, Jackson. And we also have Dr. Kendra Outler, of course, who is the brainchild behind this, anesthesiologist from the DC area. Dr. K, you have some stats that we're going to go over in just a minute too, because obviously with everything that Dr. Owens and Dr. Alexander have said today, this has to be some type of health disparity, right? That this is happening, particularly with more Black women than anyone else.
Well, while Dean gets the CDC PDF up about some of these statistics, I want to go over a couple of things here. The issue that what we're hearing about is that this medical issue is a health disparity issue, and what Dr. Alexander and Dr. Owens eloquently said, is all the medical stuff, but they also alluded to the other reasons why Black women die, because we're very unclear about what are we missing. So this was brought up, and it says, okay, now we're getting all technical, but this is very easy. We talked about the fact that 700 women die out of 100,000, but we also want to make sure that if you're a graphics person, that 2 out of 3 women who die or become ill, it's more likely is going to be an African-American woman, or the next group, highest group, is the Native American women. If you scroll up on this, the bottom, and so our numbers are the big purple line, and what we saw was that we haven't gotten better. So why are we talking about this now? Is because we really, as an advanced nation, with all of the tools and all the technology that we have, somehow or another, our group of this group of women, Black women, are not seeing decreases in maternal morbidity and mortality. And at the bottom, I think of this PDF was just a clear section that basically said that if you were educated, you still had the same risk. And so what we want to educated Black women had a higher, almost a 5-time higher risk than educated Black white women for a problem with birth. And so we saw Allison Felix, we saw Beyonce speak up, we saw Serena speak up, and what that tells us is that across socioeconomic groups, money, education status, better housing, better zip code, better transportation, closer to medical centers would not guarantee that you would survive your pregnancy. So therein lies the issue. What is the issue? And so we really need to continue to see what this evasive health disparity or race causing issue is. Because we can't change the fact that we're Black women, but maybe we change the fact that how we educate our practitioners. And we also have practitioners now, doulas and midwives that also assist in obstetrical care. We have to go back to figuring out where is the messaging where's the messaging missing, and also what we need to do on a policy standpoint. So I would say that we have a couple of things that we can do. It's like we can't change our race, but we have to address maternity deserts. We have to think about where there might be delays in care. And so the patient has to, like Dr. Alexander said, we need to recognize that maybe my shortness of breath is not due to my pregnancy and there's something wrong. Once you decide that you need to go see the doctor, then it becomes which one I need to go to. Do I need to go to the urgent care? Because people have options now. Do I need to go to the urgent care? Do I call my obstetrician? Or do I go to my community hospital? Or do I need to go to a major medical center? So those are some of the choices. And then once you get inside of the hospital care system, depending on what you choose, you may need to be transferred, which creates another delay. Or someone then has to decide what's the best action. Should we call Dr. Alexander, a heart specialist for you? And do we call the obstetrician? Or do we call the whole team? And so we call those 3 points of delays in the care for healthcare. The response to the woman's complaint can be a delay. We also talk about access. So one of the biggest issues about access is that if this is a 365 day problem after pregnancy, does the woman still have access to maternal care? And so that there lies a huge gap. And then finally, Black women enter pregnancy and with other comorbidities, which Dr. Owens mentioned, obesity. Dr. Alexander, mentioned that women have baseline high blood pressure, and the state of pregnancy can make this even worse. So you come in with some conditions, which can also put you at high risk, and you have to be able to partner with your healthcare system to hopefully ensure that you're not a statistic. So there's the number at the bottom, disparities by educational level. So I didn't make that up. And also, as we're seeing advanced moms deliver later in life, they have a higher risk of maternity and mortality. So
let me just say one thing about this. So you see, as you have pointed out, that we also have problems with educated women still having some of these issues. So you would think that, well, there's a genetic predisposition that you can't really change, right? So some of it also is cultural. So even though you have an educated person that may be the top of, she may be the head of a school or a superintendent or something, but that person's activity, I mean, the way they eat and the way they function is still has not changed, even though they know better. We're not doing better. So I think we need to continue with the encouraging our sisters, mothers, aunts, whomever. We still need to encourage them to be the best they can be, and not just consider, well, this is just going to be because I'm Black. I just don't feel like that is the answer. I think part of it is genetics, but I think part of it is cultural, that we need to change what we are doing, and exercising and changing our diets got to be part of what we're doing.
So,
But
Dr. Alexander, I wanted to say something, because you when you said that, you just like struck something in my soul. And you are right. There are things that are cultural, but the other part is you did such a great job, Dr. K, of like kind of breaking it down into like some real solid action items. But there was a couple of things that I feel like we also need to escalate. And that is, so we can educate ourselves as much as we want to. There are people that walk in with a whole bunch of degrees and a lot of extra letters behind their names. They are healthy, they eat well, and they die. Okay. So yes, it is patient education and knowledge and understanding is one thing, but the other piece is that physicians need to be educated too. And the other part of that is correcting some of the miseducation that has been perpetuated within medicine, that leads us to believe that Black woman laying on the bed is somehow different than the white woman in the room next door. Okay. So I think, so that part. And then the other piece is, people of color in this country struggle with their own advocacy because we have not been empowered to lift and raise our voices. And when that's typically done, it is shut down or locked down in ways that are intended to really repress us from speaking our truth. In the healthcare arena, self-advocacy is an imperative. And Dr. K, you mentioned doulas, midwives, and things like that. Those, having additional people on the healthcare team, being comfortable speaking your truth, telling somebody when you are not feeling right, because I can tell you about the body, but you have to tell me about your body, because what I learned is what the book said, and the book never met you. So my job is to put the book together with what you are giving me. And I think so often we will shrink away from those people who we feel like are more educated or who come across more authoritative, or in some cases are just downright dismissive of our complaints. And we'll just say, well, they didn't do nothing. Or we get frustrated because they leave us in the room for 4 hours and we leave, but we don't go to the next person to get that situation resolved. So self-advocacy is huge. And the medical community needs to catch up and recognize the issues with bias and unjust treatment, and the social racism issues that contribute to people's poor health and their situations. We need to kind of come together and figure that part out and turn that into action yesterday, so that we can stop the senseless deaths. Like over 60% of these deaths are preventable by listening to people and taking timely action, and by being in the right place at the right time.
Well, you are moving right into our Q&A section. Thank you, Dr. Owens, because Raquel Brown says, what is taught in medical books to make doctors believe we don't feel the same pain, to the point we aren't listened to? I also notice even with anesthesia for oral surgeries, whites are gassed up every time, and I haven't even been asked when or if I need any. So what you just said, what you just said, Dr. Owens. So thank you for putting that in, Raquel. We also have another question. This is, first of all, Michelle Bailey says, great webinar. Thank you, Michelle. Dana, I think that's what it is. Dana said, I had pre-eclampsia after having my baby. Is this rare? Dr. Owens will give that one to you.
So actually, no, it's not. As a matter of fact, now we're seeing about 40% of preeclampsia actually occurs after delivery or after birth. And it can occur up to, and even in some instances, beyond the first 6 weeks of after delivery. So it is not uncommon at all. Most of those people will happen within the first 2 weeks. But there are still quite a number of people who will develop preeclampsia even a month or a month and a half or even longer after birth.
Okay, so now Dr. Alexander, to piggyback on that, Dana also says, my doctor never checked back in with me after having preeclampsia, and I was on beta blockers. So I didn't know when I needed to know when to stop taking them.
Okay, so that's important as well. And there's been some legislation trying to increase especially the moms that may be on Medicaid. So we want to increase the time that they are getting, since they're having problems for a year, right? They can have problems for a year. So why not cover them for a year and not for 42 days? So that's some legislation that we need to focus on, and it would be a state by state. But since it's a broad problem, that's something that we need to take care of. And so we urge moms to seek medical attention early. You know, they can come, especially if they've had a problem already during the pregnancy, they need to follow up. Now, let me just tell you this, pre-eclampsia, the fact that you had high blood pressure during your pregnancy is a warning for what's going to happen to you in 20 years. So if you were 21, had a baby, and you had preeclampsia and you were doing fine, you are at risk for developing hypertension later on in life, and you are also at risk for developing heart disease later on in life. So that is another reason that you need to follow up with the cardiologist, or at least follow up with the internist, you know, like years later, to make sure that you're not developing heart disease. So this is it's not the end of the story after you have your baby.
Shakisha says, very informative. This is great. Thank you, Shakisha. I'm glad you're enjoying it. I hope everybody else is. We have, I think this is Baya Siddiqui says, this is off the radar for the poor, the average to the most elite. This conversation has to be a community-wide share that can occur at health fairs and other community church gatherings as such. So thank you for those kind words as well. We're trying to get it all out there. So thank you all. Dana says, thank you for the information. Do we have any closing remarks before we get out of here? Any more questions too? You can definitely put them in the chat. We'll try to get them before we leave. Dr. K, anything you want to say?
No, we're on my my Facebook, my Uzima Health and Wellness Facebook. There is going to be uploading of any of your stories, so like Allison Felix and the CDC messaging is Hear Us Now. I just want you to know we are listening. And so we definitely want to make sure that you visit my website, myuzima.org. We're working out some final glitches on this brand new website platform. We've had the .com, but now we're at .org. It's bigger and better, and it's to serve to give us more information. So I appreciate that. And also we want to continue to have your stories be heard even after we finish this webinar. After we finish here, just going over to the Uzima Health and Wellness Facebook, and you will actually see where you can upload information about any story that you want to share. And maybe we can then, again, show this community of concern, and it will spur changes. We do have the Congressional Black Caucus that will meet in September. So your legislative bodies will be at work, and we have a voice. And I think that's why we're here tonight. Also, I want to ask Dr. Alexander and Dr. Oz for some final words about some challenges and successes in where they work at the University of Mississippi Medical Center, because you do outstanding work, and like you say, with some limited resources and some as a tertiary center.
We'll start with Dr. Alexander, and then we'll
well, you know what? I think just collaborating with each other. I just recall I've been at the University of Mississippi for 10 years. And when I first got there, Michelle said to me, she said, "Hey, can you see some of these patients? Because I'm calling a cardiologist and they're acting like we don't know what we're doing." And so I said, "Okay, wait. So I had to learn myself. I wrote an article when I first started, and that helped me tremendously learn to put these two together. And the American Heart Association, they're doing it as well. We're trying to get this to be a broad field, that cardio-obstetrics, so that we won't miss this. But I would also urge, like Michelle said, ask your doctor. Now, I get some patients, they'll call me back, but don't want to ask their other doctor what's going on. So, just they owe you that, that they should have some explanation of what's going on with them.
Okay, Dr. Owens.
So I again want to just say thanks for the opportunity. It's so good to be here with my colleague, Dr. Alexander Nichols, and we are trying to make Mississippi heart healthy. But what I will say just to the listening audience, if you or someone you know or love is pregnant or has been pregnant, you know your body. And you are the expert on you. And so don't let anybody else tell you about yourself. And if you are not getting the answer that you need, if you are not getting relief, then do not stop until you get it. And you feel free to seek a second, a third, a fourth opinion in order to make sure that your voice is heard. Do not let someone dismiss your complaints. And you need to understand that the person that you have as your healthcare provider or members of your healthcare team should be people that not only care for you, but they care about you. And if you don't have that, you should find another physician.
Thank you
now,
very
let
much.
me also say this happens not just for Black women. This happens for white women too. Okay, they're dismissed as well. So a lot of times they think the women have anxiety. Okay, she got an anxiety problem. That's her problem. So it's not just us. Okay, it's across the board, just women in general. And like the young lady said, what are they teaching? It's not that they put it in the books. It's carried on from person to person. It's just something that's carried on. It's not written down.
Well, we call it the paternalistic type of approach to medicine that we've all had. I think you as a senior physician, Dr. Nichols, when you did like this, we know you're a senior. you train, with a lot of men. And unfortunately, like I tell residents, this is also not about a black or white issue. You're learning a certain behavior. And what we do know is that when medical students, they come in there all eager to be helpful, to be caring, and then they get somewhere in this system, they forget about that. They start going with the time management. Well, I didn't have time for this. I didn't have time to talk this. They're picking up habits from other physicians that say this is the way it needs to be done if you are this or if you are that specialist. And so basically, we are identifying the fact that maybe we are educating medical students to not be concerned, not for people based on race or color, but be more concerned about the business model of medicine as opposed to the human patient that they're taking care of. And so I think that we all could find common ground on how we can improve on caring about patients, no matter what color they are, what educational level they present you with, or socioeconomics, and not the VIP. Everybody's a VIP when it comes to medicine.
Yeah.
Thank you so much. This has been wonderful. This What, How, Why Wednesday, Black Women and the Maternal Health Crisis on blackdoctor.org. Thank you so much for hosting us this evening. Thank you, Dr. Myrna Alexander, clinical cardiologist, and Dr. Michelle Owens, obstetrics and gynecology, both affiliated with the University of Mississippi in Jackson. Thank you so much, Dr. Kendra Outler. Don't forget, she wants to hear your voice on the Uzima Health and Wellness Facebook page. Uzima is spelled U-Z-I-M-A. U-Z-I-M-A.
What does that mean?
Swahili for life. When I thought of Swahili for life. So that's easy. Okay.
Yeah, and share your story about this, because I'm sure many people have gone through this in their families, like Dr. K did in Finding Fosie Lee, which was the story of her aunt who passed, while having a baby. It was during childbirth, right?
Afterwards. It was after.
Yeah. You can always go to myuzima.org. That is myuzima. It has been my pleasure to be your host, Tamara G from 101.5 Light FM in Miami. Dr. K, take it away.
I want to thank you both, my friends, for coming on and hosting. Again, I applaud you all, and also the great university that you are at. Is that good English? But thank you so much for hosting. I look forward to talking to you again very soon, and again about this subject. So thank you so much. Good night.
Good night.
Tamara.